Welcome to today's webinar. My name is Blake Baucom and I'm the Director of Sales for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you have. There's a question and answer button on the right side of the screen where you can type your questions at any time and we will try to get to them answered during the webinar. Let me introduce Dr. Samarani. Dr. Raward Samarani received his DDS and Master of Science in Periodontology from the St. Joseph University of Beirut, where he is currently a part-time lecturer. He has published several scientific articles and a textbook chapter on guided bone regeneration published by Wiley Blackwell. He is a lecturer, course instructor, and runs a multi-specialty private practice with an included training facility in Byblos, Lebanon. Dr. Samarani, my friend, thank you so much for being here.
Thank you, Blake, for the introduction. Thank you, Osteogenics, also for having me. It's a pleasure, actually. So let's delve in right away. So my topic, as you can see, it's about ridge augmentation. And in the title, I've specifically mentioned the word 3D. So we're going to talk about this specific aspect of the classification of the ridge defect. And we're going to also, within this frame, within this context, we're going to talk about the need for autogenous bone in the GBR procedure precisely. So this is the university where I teach, and these are some pictures of my practice. So basically speaking, we have the habit to describe the defects in two categories: the lateral one and the vertical one. So obviously, the vertical is a 3D defect, so by default. So what about the lateral? So because most of the time we tend to consider the lateral as a simple defect, whereas in reality, it's also a 3D defect, because all lateral defects have some deficiency in the buccal, some deficiencies in the lingual, and some vertical deficiencies too. So they're also a 3D defect. So all of our defects are basically 3D. And if we're stressing this fact, it is because we need something to tackle this challenge, which is the 3D defect. So we need a technique that is destined to build in a three-dimensional way. So let's examine this specific defect. So this is a lateral defect, supposedly. So if we examine closely, we can see that we need to place the implant right in the middle, and we would need to build the bone both on the buccal and on the lingual. And if we look at the vertical component, we can notice also a small vertical deficiency, which is not very important in the posteriors, that is very important in the anteriors. So this defect that is a 3D defect was treated in a three-dimensional way in this way, and we were able to go from a 2-millimeter ridge to an almost 9-millimeter ridge and place the implant right where it should be. And also we were able to 3D build this defect in its vertical component and have a complete reconstruction of the defect. So what have we done in this case? What was our strategy? What was our treatment option? Because every time we have to treat a ridge defect, we have many options. We have the blocks. This is the mother of all techniques. So blocks are discounted nowadays because blocks, they suffer a lot of resorption, up to 60% of resorption. So this is not a good option to consider anymore, unless you do on top of a block a ridge augment, a GBR, excuse me. So you put membranes and biomaterials on top of the block just to do a camouflage. So blocks by itself is not a good option. What about ridge splitting? Do we split the ridge? Personally, I don't like splitting at all, because splitting usually it let us gain some width. But most of the time we have uncontrolled resorption in the fractured bone segment, and even worse, most of the time we have loss in the height. So ridge splitting is against this conception of trying to build in a three-dimensional way. What about Curie, the Curie technique? So Curie technique, you need to take some bone plates from the ramus, and you make some shells and some containment for the bone graft. So this is a technique that is conceived to treat the bone, the defect, in a three-dimensional way. But the problem of the Curie is that this technique is limited on resources. You need to go to the external oblique line, take a big chunk of bone, and sometimes it's not enough to treat your defect. So you're limited on resources. So you want more and you don't have enough. So that's a problem. That's a problem when you're treating, for example, a big curved ridge, like the case we're going to see later on. When you're treating a totally edentulous case, you need to cut the patient on both sides. So this is a very invasive technique, very technique sensitive. It's a good technique, but I personally stopped doing it. So I started doing it when I started my ridge augmentation endeavor, I would say. I started with the Curie, so I was very much impressed by the guy, and then I decided not anymore. I want to stop doing the Curie technique. I want something efficient, straight to the point. So my option, and my only option, is the guided bone regeneration, where you use membranes and biomaterial to treat a three-dimensional ridge defect. So in this case, precisely, we've used a titanium reinforced membrane. As you can see, it was positioned on the lingual first. So you have many options. You choose the one that fits your defect. And underneath this membrane, I've placed my preferred graft choice. We're going to talk about this graft choice in details later on. So it's a mixture between an allograft, we're going to describe it in details, with some xenograft. Okay, so that's my preferred graft choice. And in this case, we were able to go from a 2 millimeter ridge, deficient ridge, to a 3D reconstructed ridge, and that's the maintenance, perfectly stable after along the years. So again, another case, part of this introduction, just to illustrate the idea how flexible are the membranes. How flexible is a titanium reinforced membrane, for example? You can carve it, you can shape it the way you want. You have this titanium frame. For example, this ridge, look at the curvature. This curvature is a very challenging job to do, because not only you need to place some bones, you need to follow the curvature, which is a very difficult task. Nothing is better than a titanium reinforced membrane, a big one where you can carve it and shape it to have this curvature. And I invite you, to have a look at this video. This is a video. So you see, we localize the mental nerve. This is the ridge. Look how thin is the ridge. So you advance your flaps. So we're placing some tent screws here. So tent screws for the purpose to know where to position the membrane. So otherwise, because you don't see, once you fold the membrane, you don't see how deep you're pushing this membrane against the ridge. So these are like stoppers. So we stabilize the membrane, in this case buccally first, decortication, and then we apply the graft in this pouch that we've created between the recipient side and the membrane. And that's again my preferred graft, which is the allograft that we're gonna describe with some xenograft. And I'm gonna give you the rationale why I like this graft combination and how I evolved with this graft combination, and I became very confident about this specific graft. So that's the graft in place, and we just need to fold the membrane, trim it a little bit, and stabilize it around the ridge. We need to have an intimate contact between the membrane and the ridge. And now here I'm using the Profix, those small screws from Optogenics, that are a miracle, especially when you're stabilizing from the lingual side, especially on the anterior. You have no other alternative. They just go in easily. So on the buckle, you have the option of using either the pins or the screws. So we trim the excess, we shy away from the adjacent teeth, and the side is ready. Look at the curvature, look at the horseshoe shape of this graft membrane combination that we've put. So tight adaptation on all sides of the recipient side. And then now we are ready to suture. So suturing is an important step. The suturing should be done in a passive way. So the flaps should be released, advanced passively, and the closure should be hermetic and tight. This is one suture that I've proposed in one publication. So this is the suture. We don't have time to develop it. This is a suture that goes around the adjacent tooth, the tooth that is right adjacent to the denture side, and it hooks, it stabilizes the flap around this tooth to prevent flap mobility, left and right, because when your flaps are very mobile and very loose, it's easy to pull them on one side more than the other. And then when you come to close your vertical releasing incision, you're going to have some difficulties. So this suture centers the flap around the adjacent teeth to put it at its original position. And we don't worry about the middle section, because already the flap are very loose and they can easily be closed in the central part of the ridge, and that's the closure. So we're done with this video, and this is 9-month outcome. So perfectly reconstructed ridge. So we went from 1.5 millimeter to practically 9. So this is very important to have a wide enough ridge. For example, with the Curie technique or with other techniques, because the average gain is 2, 3 to 4 millimeters, sometimes a little more. So if you're starting with the 2 millimeter and you gain with a block technique only 3 millimeters, you're at 5. You're still in trouble, because if you need a safe bony environment, you need at least 8, 9, and 10 millimeters. You need to account for some remodeling of the ridge that's gonna happen inevitably. So look at the horseshoe shape. This is a beauty for someone who appreciates bone grafting. This is a very beautifully shaped ridge, and we have a little of an excess, some amount of excess. The implants need to be placed little subcrestal, and then this is the occlusal view, and this is after 3 months at abutment connection. I invite you to have a look at the probe. Here in this photo, I'm putting the probe and I'm leaning over the probe. I'm putting my weight on this probe to try to for the probe to try to penetrate it inside the newly formed bone, and is not getting through. Why? Because this bone has matured enough, is corticalized, is lamellar bone, and this is a proof, a visual proof. So you don't need histology here. You don't need to take a core biopsy and send it to the lab to know how much newly formed bone I have, because this bone is very resistant to penetration. So this is a nice, because most of the time, or sometimes, when in ridge augmentation under those titanium reinforced membranes, whether you use autogenous bone or anything else, you have this little movement on the surface. You have the feeling that is not very well rigid, I would say, but it's consolidated somehow, but it's a little mobile. So this maturation comes after you remove this membrane, after this interaction is taking place with the periosteum. So everything is maturing, and after a couple of months, you see this hardness. So zero autogenous bone, completely regenerated 3D grafted ridge. So we've presented 2 cases with titanium reinforced membrane, but GBR is not always performed with a non-resolvable membrane, with a titanium reinforced membrane, because collagen membrane have their place too, have their lion's share, I would say, because most of the membranes used among dentists are collagen membrane. So what about collagen membrane in the GBR? So if we're opening this chapter, this topic, the collagen membrane, we shouldn't overlook this group. This is the Danny Buser group from the Bern University in Switzerland. They're probably the best group, the group that has published the best on the topic, and they have the longest follow-up on a ridge augmentation using a collagen membrane. But according to the philosophy of this group, they use a non-cross-linked collagen membrane, so a native collagen membrane like Geistlich, for example. So, and they believe that because of the collagen is flimsy, has no structure, you need to put underneath this collagen membrane something rigid to give it structure and strength. So they put a block, and on top of the block, they do their GBR. So this was the dominant school, I would say, if you want to use predictably collagen membrane and biomaterials, so GBR, for ridge augmentation. We're not talking about small dehiscence type defects here through ridge augmentation. So this is a major landmark in this field. And this was true until this publication. So I bet you all know Istvan Urban is very famous all around the world. So when Istvan came about and he published this paper, he said, guys, look, I don't need your blocks. I don't need this piece of bone that you retrieve from the ramus or from the chin to put something rigid underneath this collagen membrane. I just need to pack my graft and stabilize it like crazy with pins to have something like a sausage. And this would be enough for me. And he published some results, and his results were amazing because the average that he published was 5.7 millimeter. And the previous group were publishing around 4 to 5 millimeters. So it was like a revolution in the area of ridge augmentation using collagen membrane and biomaterials. So we don't need the blocks anymore, according to Istvan. Some people were skeptical at the beginning, but it proved to be a very good technique. So I personally was very much impressed by Istvan when I met him, when I saw his material, and I put myself on his technique. And this is this small technical modification, which is the mobilization of the graft membrane complex in this crazy way. So you put tags all over, everything is stable, pays back. So this is something that is efficient. It makes a difference, a sensible difference. So this would be one of my options that I would adopt. So being inspired by Istvan, I developed with the years something personal, like a personal approach inspired by Istvan's technique, and I gave it a name just to grab attention, just to incite curiosity. So Istvan technique is called sausage technique. So my personal approach, I like to name it reverse sausage technique. I'm gonna detail it later on. So one aspect is that I use 10 screws because I believe that 10 screws are an extra boost for Istvan's urban philosophy. So his concept of stabilizing everything is great, is very efficient. But adding to this some 10 screws is an extra boost to the procedure. And I'm showing you this. So we had a sinus that we had to deal with, and we put 10 screws both on the buccal and on the lingual. And just to remind you, here our plan is to use a collagen membrane, not a titanium reinforced membrane, because usually these kind of defects, if you want to treat it with GBR, you have to use a titanium reinforced membrane because they are the most predictable type of membranes, and the defect is challenging. So we're building bone both on the buccal and on the lingual. But just a proof of just for you to see, because I trust this approach. So this is a very extreme case treated with collagen membrane. So you can see. So we've put the graft combination that I like so much, this mixture of allograft and xenograft, and I've covered everything with a cross-linked collagen membrane. So not a native one, like advocated by the Burn School group, like advocated by Istvan Urban group. I use something else. I use a cross-linked membrane. So cross-linking is a process, a chemical process where you increase the bond between the collagen fibers to give the membrane a longer barrier function, because typically a native membrane lasts about 4 to 6 weeks, whereas this type of membranes can go up to 4, 5, 6 months. So the difference is sensible, is important. So I trust this idea, this concept of collagen membrane, where you modify the collagen to give it longevity, for the barrier function to be there for a longer period of time. So and I invite you to have a look at the result. So we went from 2 millimeters to almost 9 millimeters, something very similar to a titanium reinforced membrane with only collagen. So this is something important. So the combination here. So the combination here is this sausage. So you see, I stabilized everything like crazy. The 10 that help boost. I'm going to show you other examples for you to be convinced how important are the 10 screws and the graft and membrane combination. So this is the outcome, and this is before, and this is after. So if I'm showing all this, it is to say that GBR has evolved, and it's not the technique, the baby technique. It's not the technique that is indicated for small dehiscence type defect, because at the beginning, 30 years back, I don't know, in the 90s, the GBR was conceived to treat small dehiscence type defects around implant threads. But this technique has evolved with the years. Now we're treating very complex 3D ridge defects. We're treating extremely atrophic jaws. We're treating even cleft palate, which were the exclusive arena of maxillofacial surgeons. When you go to the surgeon and you take a piece of your hip bone and you graft the cleft. So now we can treat it with GBR. So it's basically for every indication, at least in my perspective. So I use GBR for every single defect without thinking twice. So this is my approach. So what about the graft material of choice? So as you know, you have so many. You have autogenous, allo, xeno, synthetic, so many different options to the point that it gets confusing. So selecting a graft of choice is a difficult task, is a daunting task for the dentist, especially that, scientifically speaking, we don't have enough comparative clinical trials comparing the efficacy of these grafts in a controlled clinical trial. So this is something that is seriously lacking in the literature. We have so many case reports here and there, but nothing really serious comparative trials. So the choice is difficult. So I'm not gonna go through all of them. I'm gonna focus on the allograft. So, allograft, we have two types. We have the one that is demineralized, and we have the one that is mineralized. So basically, the demineralized, the one on the left, has no structure, has no mineral. It is demineralized to expose a certain protein in it called the BMP2, which is a very important protein that induces bone formation. Whereas the one on the right, the FDBA, as you can see, it has more structure because it has mineral. It was conceived for its osteoconductive property. So basically, the DFDBA is osteoinductive. This is for this reason that we like DFDBA, and especially when the DFDBA, is coming from a provider that is testing its product for osteoinductivity, like Osteogenic does with the Anchor, for example. That's why I like the Anchor. So they test every single lot that is osteoinductive. This osteoinductive means you take this material and you put it in the skin, not in a bony environment, in the skin of the rat. So you put it in the skin and you come back after a while and you see that bone is forming because of this material in the skin of the rat in a non-bony environment. That means pure osteoinduction. So if you're taking your graft from a provider that is controlling this, so your DFDBA is osteoinductive. So this is a very important point. So DFDBA was considered by many, especially at the beginning of the GBR, to be as equivalent as autogenous bone by so many people, like Simeon, the godfather of vertical augmentation, Melonic, very famous periodontist. And according to Simeon, so he used to see DFDBA as equivalent to autogenous bone, except in vertical defects that are superior to 4 millimeters. So only above 4 millimeters in vertical, he would advise autogenous bone. So in animal studies, it was as equivalent as autogenous bone, and superior to bios, synthetic. So this was proven. This is a proven fact. And in sockets, the performance was great by the San Antonio group. Excellent performance. One thing, one doubt, one reserve about the DFDBA is that it resorbs, and this is something that was stated by so many clinicians, notably Simeon, but not in a very scientific way. So it was not a study that was conducted and it was proven that it resorbs. This was just like a remark given by a very famous authority. So Whereas the FDBA, talking about the FDBA, this is more of an osteoconductive product because the HA is there, the mineral is there, it conducts bone to form. It's not osteoinductive, excuse me. And the important aspect of FDBA is that it does not resorb as quick as the FDBA. So it stays there longer. So we have two different kinetics, two different dynamics between the two. And it was tested in different clinical scenarios, and the outcome was great, and also no data on marginal bone remodeling with FDBA. So if I exposed the advantages of both is to come to this point. So each one has its own, each one has some advantages. So what about mixing the two? What about mixing the FDBA and the DFDBA and take the advantages of both words? So what about it? So it's a great idea. And that's exactly the product that I like. That's exactly the product that I like to use from osteogenics. It's called the Anchor 70/30. It's 70% the mineral part and 30% the demineralized part, the osteoinductive part. So this product, I like to mix it with some xenograft. I'll tell you later why. So I've been using this product since its launch, since 2010. So I've used also some others, but this product I like so much. So I'm gonna tell you my story quickly, briefly, my story about this graft. I've used it in the sinus, and look at that. So you come back after 7 months, you don't see the trace of your sinus bone graft. So this was only happening to me when I use a sinus graft with autogenous bone. You see, in this case, I've used autogenous bone, and you don't see any trace of the window. And this used to happen only with autogenous bone for me, especially that I was not educated to allograft. So allografts were alien to me because in my school, in my university, we were very much influenced by the European school where they don't have allografts. So we were educated to use autogenous bone xenografts. And when I decided to test this product, I was amazed because I've seen something clinically, at least, as similar, as effective as autogenous bone. Whereas in the xenograft, look at this sinus with xenograft. So after 9 months, you come and you put the probe sideways like that in the sinus window, and the probe penetrates, it goes through. It doesn't mean that the implant are not going to be successful. It was proven that they will be successful with a high success rate, but the clinical healing is different. So it's very different. So I've tested it in the socket. Look at this socket preservation with the cytoplast technique. You see this with this allograft. At 6 months, you see bone. You see nothing else. Complete corticalization of the socket. Whereas in xenograft, you come after 6 months, you see those granules, this mixture of new bone formation, of some granulation tissue, and some biomaterials. And we know that from the studies of Araujo. So we know if we put xenograft in the socket, we're delaying the bone formation. So we're taking the advantage of preserving the volume, but we're delaying bone formation. We're not seeing that with allograft. So after testing this product, because I started very cautiously with this product, I was very much impressed. Sinus, socket, beautiful. So I started using it in the ridge. So, and here comes the most interesting part of my journey with allografts. So look at this case. I'm showing you different outcomes with this allograft. So in this case, I had an excellent outcome. I've used this allograft alone. And look at that, very favorable outcome at 6 months. You see this bulge of bone out there was able to build with the collagen membrane, but it didn't always happen like that. So I had, especially in the ridge, with allografts, I had a lot of variability. I had a lot of variability in outcomes. Sometimes I had good, nice volume, sometimes average, sometimes small, and it was not stable and consistent. And I'm showing you here another case where the result was very little, probably 80 to 90% of the graft that I put in a ridge augmentation environment here, not socket, not sinus, has resorbed. It just disappeared. So I'm showing here another case. So this is a big vertical augmentation combined with the sinus communication. So big defect, you see. So I was able here, I'm not using collagen, I'm using titanium reinforced. So we were able to build the ridge on a 14 millimeter ridge height, which is a lot. In width is 10 millimeter, which is a lot. So very successful regeneration. And after we've placed the implant and we came back for abutment connection, that's what we've encountered. So part of this ridge that we were able to ridge was dying out, was resorbing like sugar in water. So it didn't happen every time and every now and then. Probably it would happen less with the mineralized cortical, because here we have, it's a mixture of FDBA and DFDBA, but it happens from now and sometimes. So, and I've discovered after a couple of years that allograft are great. They're just like autogenous bone in terms of bone quality, but also they're similar to autogenous bone in terms of resorption and remodeling, because they are subject to remodeling like autogenous bone. So, and it was stated in some papers that sometimes we have 50%, 68% of bone volume loss while using the FDBA, for example. So it was something that is stated. So in 2011, I met Isvan in Beirut. So we invited him for a lecture, and this was 2 years before his publication, because he published his work about the sausage in 2013. So in 2011, already he had a very nice material, and he was advocating, he was preaching for this combination, autogenous bone and xenograft. Why? Because autogenous bone is the graft that has the biological potential, and bovine bone is the part that is going to work against resorption. It's going to be like the stabilizer. It's going to be the component inside this graft that's going to give the graft some stability. And this was something that was advocated by Simeon in 2007, by Boyne, where he was reconstructing with the titanium mesh the full arches. So very famous maxillofacial surgeon. So it was proposed by so many people. So, and I decided, I thought to myself, why I wouldn't do the same? Because I like this allograft. I liked it so much, but I have sometimes some resorption. I don't have a consistently stable volume. So I decided to do something like that. Like those people, I decided to mix this allograft that I like so much with some bovine bone to give it stability over time. And allografts, they contain, like autogenous bone, they contain collagen, BMP2, and it was proven that they contain also TGF-beta and some other proteins. And in this graft combination, now we have three kinetics, three speed. First, the DFDBA that resolves quickly, and it is osteoconductive. Second, the FDBA that has an average speed of resorption, and it's very osteoconductive. And then the bovine bone that's a good osteoconductive, and practically it does not resorb. So we have three different dynamics, and also working, I would say, this resorption dynamics goes along the maturation of the bone, the formation of the bone, because the bone does not form in one time. It takes time to build layer after layer. And while the bone is building layer after layer, some part of the graft are going away and new bone is taking place. So we have more bone inside the newly formed bone. So that's the idea. So the sausage technique of Istvan, we were talking about it. He likes to use native. He likes to use autogenous plus xenograft, as we've mentioned. He likes to lingually tag the membrane first. From a technical perspective, this is something that he stresses on so much. Lingual fixation first, and then he packs buccally, and of course everything is stabilized. Whereas the approach that was inspired from Istvan, that I like to call it reverse sausage, just for the purpose of, I repeat, just for the purpose to grab some attention, I would say. So I like to use crosslink because I like crosslink, like we've mentioned. I replace the autogenous with allograft, And I like to do buccal fixation first because I believe buccal is better because you put your membrane buccal and you create a kind of pouch that is easy to pack and to build and to overfill if you want to. And I like to add to the sausage 10 screws. It's an extra boost and everything is stabilized like Istvan's recommendation. So I'm gonna go with you quickly over some clinical cases. So look at this case. This is a small dehiscence type defect on short implants. I'm talking about the two distal implants. So they're already short. So we're already compromising on height. We shouldn't compromise on bone width. So whatever dehiscence we have, we need to build it in those cases. So I'm starting with you from small defects to bigger ones. So look at that. So I've stabilized the membrane buccally first to create this kangaroo pouch. And you just need to pack. So from a technical point of view, it's more convenient. And you can also build and pack and make it bigger as much as you want. And always I use the same graft combination, which is demineralized 70-30 combination with some bovine bone. And look at that. Everything is stabilized, the sausage way, and look at the outcome. This is at 10 months. In this case, unintentionally, the patient was left at 10 months because he was away, but I invite you to have a look at the healing. So this is something beautiful, beautiful. Close-up view, look at that. So everything is completely corticalized. And if you look closer, you can see those small white particles. These are the bovine bone particles that are encrusted, embedded in the newly formed bone. And this is at 10 months. We could have entered this case earlier, of course. We don't need to wait that much, but accidentally it stayed till 10 months, and you can see the quality of bone. So we had to take the burr, and cut the bone to expose those implant heads. And as you can see, we were able to have something like that. So even the peak of bone in between the implants was reconstructed. And look at that occlusally, nicely built bone. So now we're moving to a bigger type of defect. So it's more of a circumferential defect. It's much more than a dehiscence here. So just to show you the potential of using this technique for simultaneously with the implants. This combination, this graft membrane combination. So buccally first. Buccally is good because you know your limit. If you have a mental nerve, for example, you just know what it is. You just spare it, you put your limit, you set your limit, and you're quiet. You don't need to worry about that anymore. And you just need to pack the pouch and wrap everything over, stabilized in the sausage way. And as you can see, so I want you to see the stretch marks on this membrane. It's a sign that everything is tightly secured over the graft, over the ridge. And look at this before and after. I invite you to closely examine the difference. How much bone volume you think I've lost? So probably 5%, 10 maximum. And this is consistent every now and then. It's been like 10 years. Every time I use this combination, it's every time most of the graft that I have underneath this cross-linked collagen membrane is transformed into bone. So this is something that I've never seen before. Not with Geistlich, not with anything, any combination. Even with the regular sausage, you lose. It's not documented, it's not published, but I trust that you lose because I use it from time to time just for the sake of curiosity. You lose, sometimes you lose 20, 30. And I've put one of my students at the university, we're doing now a randomized clinical trial between the regular sausage and this technique just to know exactly how much do you lose, because I trust that the cross-linked membrane preserves the bone volume more than the native, because the native, they resolve quickly and the bone graft is exposed easily. So this is before and after, and this is the follow-up, very much stable over the years. So I'm going to show you some deceptions of the sausage, because in every technique every technique has its own deceptions. So Sometimes you're deceived with the sausage. I'll tell you how, why, especially when you have a single tooth. Because when you have a single tooth, you stretch your flap and you have a lot of tension in this flap. And this tension in the flap flatten the bone graft and the membrane underneath. And look what happens. So I've encountered this problem many times. And now when I have a single tooth, I don't do a regular sausage. I'll tell you what I do later on. So nicely fitted, nicely stabilized sausage. Look at that, beautifully, no mistake. Everything is well adapted, tightly fit, no problem. This is the suture and this is the closure. And look at the problem, look at the deception, look at the concavity, look at the flattening. It's not that the bone has resolved here. No, the bone is here. The bone has shifted apically. We had the translation because the tension of the flap, because we have so much tension when you have a single tooth. So there is a flattening effect of the ridge of the flap, of the overlying flap, and we have this. So if I have an aesthetic area, I have a single tooth, I don't do a sausage. I do something else. So you see the problem? What I do, if I insist on using collagen membrane, I use underneath this collagen membrane a 10 screw. It's going to be a shield that will protect my graft membrane system from collapsing. So I like to use those 10 screws. They're just very efficient. So look at this case. So dehiscence, big dehiscence. So I've put left and right 2 10 screws just to shield this area from the flattening effect of the flap. The sausage, the reverse sausage, I like to call it. So no autogenous bone, exclusively the 70-30 graft with some bovine bone. And look at that. There's no trace of the implant anymore. Everything is buried, completely covered by newly formed bone. We had some bone loss. If you examine closely, you see where I put the mark, we had some collapse right in the middle. The collapse took place at the point where we don't have a tent in the middle. So, but on the side, it was shielded and we had enough bone to cover this implant. And like every time, we need to take the burr and cut the bone and expose the implant because the bone is completely covered by newly formed bone without using any autogenous bone. So this is before and this is after, before and after, and we're moving to another case. This is a quick presentation of this case just to show you. So this is a vivid example, a visual proof that the 10 screws are efficient. You see in this case, at the precise location where I have the 10 screws, I don't have a collapse in the bone volume underneath. So the 10 screws acted like a shield. And look at this sideway view. You see where at the specific point where I have the 10 screws, I have this cone of bone, this volcano, this bulge of bone that is protruding outside the newly formed ridge and is coming around this 10 screws, this 10 screw. So this 10 screw, so this is a very vivid example. So had I placed a third one, I would have had something better, but already the plan is to place only 2 implants. So you see, so at the exact location of the 10 screws, I have maximized my bone gain. So this is another time a proof that the 10 screws are an extra boost for the sausage. Look at this case. So unlike in the previous case where I've put 2 10 screws on the 2 sides of the implant, here I've placed it in the middle. And if you can place 1 in the middle, it's better than placing 2. But you should place your implant later on at a different stage. So the best thing is to place 1 10 screw in the middle if you're using a sausage in the aesthetic area. Otherwise, if you don't want to use a 10 screw, use a titanium reinforced membrane because it's even more predictable. This is the most predictable type of membrane. So look at that. And exactly, I want you to see this sideway view. Look at this sideway view. You see the bone is there at the precise location of the 10 screws. It's like a bulge of bone going outside, protruding outside the ridge and coming around this 10 screws that was playing the role of a shield, of a defender from collapse. So another quick example. Look at this case. For this case, this patient came to consult she was not concerned that she doesn't have teeth. She knows that she can have implants. She had a problem, an accident, but her concern was more the concavity here. So when you have to build this complex ridge, the ideal indication is titanium reinforced membrane. So titanium reinforced membrane should be your first choice. But because this specific patient was always on travel and she was not around, because titanium reinforced membrane, you need to have the patient always around, because in case of any misfortune, you need to intervene. So in this case, I've decided to, because with time, I started to trust more this collagen membrane. And some cases, I started to use this collagen membrane at cases where a titanium reinforced membrane should be indicated, should be advised. So look at this. So we had some vertical component that needed to be treated. Not a very thin ridge, but I've used only one 10 screw right in the middle, right at the point where I need the tenting the most to prevent the collapse. And I want you to see the outcome. No autogenous bone, again, the same combination. And look at that. So newly formed bone, everything has blood, is vital. And I want you to see this close-up view around the pins. You see this newly formed bone grew to the point that it is covering now the pins that were placed without any bone coming over them, but it has the potential to grow and cover and grow again. And I remind you, no autogenous bone was used here. And look at the vitality of the graft from a close-up view. And the most important for me is this sideway view. You see, this is the location where I was the most afraid from collapse. And because I've put this 10 screw right in the middle, so I've prevented the collapse here as much as I can. Had I've used the titanium reinforced membrane, of course, it would have been better. But for the circumstances of this patient, the result was optimized while using the collagen membrane and not using any autogenous bone. And this is the follow-up of the case. So I want to come to the indication here, the aesthetic cases. So in the aesthetic area, so this patient suffers from a periodontal disease, obviously, and she has two roots that needs to be extracted. So those cases where we have a high lip line are the most demanding cases, the most frustrating cases, because if the patient is demanding an even gingival margin, an even gingival contour, this is something very difficult, especially when you have two edentulous sites, like in this case. So in those cases where it's very critical, you shouldn't go for the second best. You should go for the best option available, which is the titanium reinforced membrane. These are the most predictable membranes, and this should be your first choice in the aesthetic area. So after treating the periodontal problem, after extracting the teeth, that's the defect that we've left with. So in this case, we have a 5 millimeter of vertical component, and we've selected the titanium reinforced membrane, like we've mentioned, and exactly the same graft every now and then. The 70-30 with some xenograft, and everything is stabilized and carved in a nice way to replicate the original ridge shape. And again, I invite you to have a look at this sideway view and to appreciate the angle that we were able to recreate. And this is because of the titanium frame. We were able to create this angle between the occlusal and the buccal, and this is very important to recreate. Can you recreate this one with a block graft? No. With the Curie technique? Probably not. With a ridge split? No, you lose more. So the only way to have something predictable and to optimize your graft is to use a titanium reinforced membrane. And the good news is that you can use it without any autogenous bone. So it's even more practical. So the implants were placed. And as you can see at abutment connection, this newly formed bone that we've built over a height of 5 millimeter was able to grow even more. So this is a proof that this is a newly formed bone. We don't need a core biopsy here. We're witnessing that the bone here is vital and is growing even more. So some connective tissue graft was used, and the soft tissue was carved. So this is a very difficult job here, the temporization, sometimes more difficult than the surgery itself, to sculpt the tissue and have something that looks like a papilla, especially in between those two teeth. Look at the occlusal view, how the ridge was nicely formed, and look at the pseudo papilla that we were able to form, which is a very difficult task. And that's the temporaries, the crowns. I'm gonna be quick with that because we have some minutes left. I guess, yeah, 8 minutes. So, and I invite you to appreciate the outcome in this very challenging case, aesthetic case. And this is the follow-up. This is after 6 years, everything is maturing. And because of the connective tissue graft that we've used, we have some kind of a rebound. So everything is like coming towards the crown even more from different views. And this is the follow-up. Perfectly stable bone around those two implants. So the bone is vital, the bone is stable, and everything is as it should be. So I'm gonna go now to a vertical augmentation of in the posterior area. So in this case, because I mentioned in the beginning that according to Simeon back in 2000, I mean 20 years back, he used to believe that the 4 millimeter is the threshold if you want to use DFDBA. So more than 4 in the vertical direction, you should definitely use autogenous bone. And again, this was not something based on an experiment. It was like his opinion out of a case series. But this idea stayed around, was going around left and right. So wherever you go, wherever you see people. So no, in the vertical dimension, no, you cannot go vertical without autogenous bone. 6 millimeter vertical, no. So in this case, because with time I gain confidence with this approach, and I've seen exactly every time the same result. I didn't publish yet, so this is something in prep. It's gonna come out soon. I've described this approach in a textbook chapter published lately, but it's not a clear case series and documentation of all the aspects of this approach. So look at this case, 6 millimeter in vertical. So again, the 70-30 mixed with some xenograft and covered with a titanium reinforced membrane. And I want you to see the outcome. So we were barely able to place a 2 millimeter implant above the nerve. Now we're able to place 6 or 7, I don't remember. And look at this option here. Look at the healing. The healing is different. It's completely different. If you recall the first case where we had this complete bone corticalization over the ridge, this is different here. Of course, it is different because here we're pushing the limit. So the newly formed bone has to travel a longer distance from the host site. So it has to go up 6-7 millimeter upwards, which is a challenging job biologically, I would say. So of course we're gonna have this granular aspect on the surface, but you shouldn't be worried about this granular aspect if you have it, because this is only the surface, and this happens exactly in the similar manner whether you use autogenous bone with the xenograft or allograft. So no difference. So these particles on the surface, you just need to grab them, take them away if you want to. You can leave them. You can place your implants. And I've taken a biopsy here. We don't have time to run through histology. And this is something very interesting I want to show you. You see, part of this bone is moving. So on purpose, I've put some pressure on this bone, and I try to move it left and right, and it's moving. Just for the skeptical to see that you have this bone moving, and then after a while, everything consolidates and becomes rock solid. And this happens in exactly the same way, whether with autogenous or with allograft. No difference. So That's at abutment connection. I've waited 5 months here when you have this aspect, this mobility, when you're building vertically. Uh, uh, so we wait 4 to 5 months, and you can see in the middle how everything becomes solid. Nothing is moving anymore. So this bone matured enough, and it became very solid around these newly placed implants. And look at the follow-up. This case was done in 2016. These are the 2020 X-ray, perfectly stable bone around this case. So and I'm seeing this patient regularly lately, so it's no problem. A quick case showing histology. Quick histology. So look at this case: vertical augmentation, 7 millimeters, same graft. And when you're building the the bone vertically on 7 millimeters, and you take a core biopsy and you have this density of bone inside the trifine, that means that you have a lot of bone. You don't need to send the core to the lab, because most of the time with sinuses, for example, you take a core biopsy sideways, you don't dare removing the bone from inside the trifine because everything will disperse, everything will be detached. But when you have it in one piece, that means that your bone graft is successful. And in this case, I've sent it to the lab. We have a 26% of newly formed bone, which is great. So I'm going to finish with two cases. This is the extremely atrophic maxilla. This is a new indication for the ridge augmentation. A very interesting indication, because the extremely atrophic maxilla is a chapter on its own in ridge augmentation, and usually it was treated by hip graft, by maxillofacial surgeons, calvarial bone, zygoma implants, so very invasive surgeries. So if you want to treat your patient by GBR without using any gram of autogenous bone, it's possible. So this is the protocol that I follow. So you see, we have practically no bone underneath the nasal floor, underneath the sinus. So in this case, we open the sinus, two sinuses bilaterally. We managed to place some implants, some regular implants for the sake of temporization. And then we graft the sinus and the ridge exactly in the same manner. As you can see, exactly in the same manner in one go, left and right, and the implants. And as you can see, so we left the patient to heal for some month. So she was away for a while, and then she came back. Look at this on the left and on the right. What you see in light gray is the original ridge, and what you see in white is the newly formed ridge. So now you can place a 5 millimeter by 15 if you want to. Everything is solid and stable, no autogenous bone, and the patient, moreover, it was temporized also with those temporary abutments. So if you have a thin ridge underneath the sinus, and if you want to extend your bone buildup anterior to the sinus, you can do it simultaneously, sinus and ridge at the same time, without any autogenous bone, no hip graft, no calvarial graft. So in this case, it was, and this is the follow-up at 6 years. I'm going to end with this case. Also, a new indication for GBR is the cleft. So the cleft is not something that was from the domain of periodontists or for people using membranes and some biomaterials. No, this is a serious defect that you need to go to the hospital and take bone from the hip and graft the defect. So in those cases, the protocol that we are developing, case after case, we don't have so many of these cases, but just for the sake of illustration here. So you remove this strip of gingiva that is clefted, because it's gonna create troubles, and we make lateral sliding flaps on the buccal and on the palatal, both together. So you see, we lateralize everything. So it's a big flap from molar to molar. And we do exactly the same thing on the palate. And we do a small slit in the posterior. And then everything is covered like usual, like any other case. We don't have a bone at the bottom, at the sinus floor, at the nasal floor, but it's no problem. It's not a big, wide defect anyhow. So it should be predictable. And indeed, look at this case. So newly formed bone, new bone was formed. And while I was doing this connective tissue graft correction, I had the possibility to sneak at this bone after its maturation, and look how hard it is. I'm pushing against the bone with my probe and nothing is going in. Everything is hard and rock solid. And I can finish with this slide. So to answer the initial question, is autogenous bone absolutely needed? I guess you can figure out my question by my answer. Probably not. Thank you.
Yeah, Dr. Samarani, great presentation and really lots of really good information there. So thank you so much for that. We've got a few questions that have come in now from the question and answer standpoint. Maybe we have a time for a couple more if you would like to add those there. Use the question and answer button in the top right-hand side of your screen. But Dr. Samarani, here's a couple questions for you. The first one is, what is your experience as far as adding growth factors to your bone grafts goes? Have you used any bone grafts? Growth factors.
I have no experience whatsoever with the growth factors. I mean, recombinant growth factors that are growth factors grown in the lab with genetic engineering technology, like the BMP2. I have no experience whatsoever. But I don't think there's a need to go and look for this extra mile, for this extra armamentarium, because already what we have in hand is very efficient already. Because we don't know how what are the side effects yet. There's a lot of edema. We don't know how predictable is the newly formed bone. So you need to use it with a titanium mesh, and you shouldn't cover it with the membrane for it to interact with the periosteum. But we don't know exactly how much bone is going to form underneath this titanium mesh. So is it going to be filled 100%? We don't know. So a lot of uncertainties, and I think it's not needed.
Yeah, great answer. And I mean, obviously, your results speak for themselves there, so maybe there's no need. All right, another question here. What is your opinion on adding more graft material at the time of implant placement to help protect the graft from resorption?
On top of an implant, or on top of? I didn't get the question right.
After you've gone back and removed, you've gone back in, you're going to place the implants. There are other lectures,
Okay.
Dr. Urban, for
Okay.
about this.
Yeah. I know exactly what's being mentioned, what's being alluded to. Is when he calls it. I don't know. He has a name for it. So after doing his vertical augmentation, he places a layer of bios, a layer of bovine bone on top, and he covers it with a collagen membrane just to protect the newly formed bone from resorbing and to give an extra volume. So this is something that I've never tried, and I don't want to try for a reason, because I don't like bovine bone on the surface, because bovine bone, they sometimes they just pop up like popcorn. They start to exfoliate, and they create small fistula tracts, and sometimes they create infection. It could happen, and sometimes this small problem can be right next to the implant surface and could be the spark of a peri-implantitis that is going to ruin the case. So I don't like this bios, this bovine bone spread on the surface. I don't know how much of it is going to integrate, especially that is grafted on top of a grafted site. I don't know. Anyhow, Isman is giving this recommendation. So we have to see if he's publishing, if he's documenting complications about that. So Isvan is a big expert. So I don't know. I trust him a lot. I'm inspired by him a lot. So, but this is one particular thing that I think, I don't know, I have some reserves.
Sure. No, it makes great sense. There's obviously many ways to do things differently, and your way is clearly working for you very well. So, a great answer. Last question here is from a handling perspective. Is there a reason that you like the cross-linked membranes, or is your preference really based around barrier function?
Yeah, it's precisely that, barrier function. So because cross-linking is made to extend the barrier function, and I want that, because GBR was founded on the principle of barrier function. So because initially GBR was made with a titanium with the non-resolvable membrane, and collagen was only an alternative just to make things easier, to reduce complication. And we started convincing ourselves that 4 weeks and 5 weeks are more than enough. So if we trust that, so we're sacrificing the basic principle of GBR, which is the barrier function. So it should be long enough in place for bone to mature, to have enough maturity and enough buildup. So I know that this debate is raging for over 20 years or so now, and we don't have clear answers for that. So the rationale for the people trusting the native is that we don't need the membrane after 4 to 6 weeks, and we need this interaction and this new blood infusion to have the bone more mature. It makes sense, but I think the price for that is that you lose more bone volume. But this is only my opinion. We don't have any proof, neither in this direction, neither in the other. So this debate is here and is going to stay for a while until clear scientific answers are given.
Absolutely not. It's again another great answer, and your results speak for themselves. So there's no real reason to even question that at this point, I would think. So
No,
that's the end of the question.
one thing I need to add concerning this point. So for the cross-linked, the cross-linked is being attacked for harboring this chemical used in cross-linking, whether glutaraldehyde or sugar or anything else. So this is the critique against the cross-link mainly, because this added chemical can potentially have a foreign body reaction, inflammation that would hamper new bone formation and bone differentiation. So that's the critique. But it was not proven to be right because foreign body reaction was documented only in close intimacy with this membrane and not at a distance from this membrane. And foreign body reaction was also recorded with in some papers with the native and also with PTFE, which is the most inert material. So this is not a clear parameter to judge on that. So one other thing that is being criticized with the crosslink is their handling characteristics. This is true. Cross-linked are more difficult to handle. They're more prone to tear. This is true. But I prefer to bear this problem, to take this problem and gain longevity.
Okay, so for you, as long as it's got the barrier function, you can get around the handling characteristics. And really, I think your
Yeah.
tenting screws are helping there quite a bit anyway. So it all makes great sense. So we've gone over here about 8 minutes. So I appreciate everybody's time. Dr. Samarani, I want to thank you again for giving us your time. I know it's very late there for you at home, and we appreciate you
It
staying
was a
up late
pleasure.
to help everybody. So, okay, thank you everybody for watching. Hope you enjoyed the webinar. We will send out a feedback survey shortly after this is over, and then we'll also send out a promotional offer with that email as well. So, again, thanks everybody for your time. We think this webinar is going to be really informative and help you support your growing dental practices. If there's anything else we can do, let us know. If not, thanks everybody, and have a great night.